This is a grand rounds for our lifespan IPC, Interprofessional Collaborative. And we've been talking about this issue of transition from pediatric to adult care for various populations of kids, those with health conditions and any kind of problems. And I couldn't think of a better speaker to have than our speaker today, Dr. Liz Sellers. Let me just tell you a little bit about her. Dr. Sellers got her medical degree from the University of Western Ontario. She did her residency in Eastern Ontario and her endocrine fellowship in Montreal at McGill. She's been at University of Manitoba. She's coming to us today from the far regions of the north in Canada, where it's snowing currently, which they love in Canada. Believe it or not, they do. And she is a professor in the Department of Pediatrics and Child Health. Her primary research over the years has been really understanding, treating, supporting kids with type 2 diabetes. Dr. Sellers is a pediatric endocrinologist by training, as I mentioned. But she also has had very special interests in kids with type 2 diabetes from Aboriginal or Indigenous populations, Indian populations in Western Canada. But she's also had a really special interest in the transition of kids from pediatric to adult healthcare systems. Over the years, she's gotten many awards for her teaching. She's published well over 100 peer-reviewed papers. She's been funded as an investigator from the Canadian Institute of Health Research, which is kind of like the Canadian NIH. And today she's going to speak about Almost an Adult, the transition tumult. So thanks, Dr. Sellers, for joining us today.
Thank you very much for that kind indication. I was saying earlier, this is not an area I feel like I'm an expert in, but a participant in, because it's an ongoing struggle for all of us who work with young adults and as a mother of young adults. I very much appreciate the opportunity to meet with you folks and hopefully have some time for discussion. I would like to start out by acknowledging the original peoples on whose lands we meet, both in Manitoba and in Florida, and pay my respects to the elders past, present, and future. I don't think I have any relevant conflicts of interest to declare related to this presentation. I certainly do have some biases, and I think relevant to this population, my biggest bias is I have very much a pediatric lens, and I will try to be a bit careful of that. So just to set the stage of where you are and where I am, this is you folks down here in Florida. This is Manitoba, which is often considered a prairie province, though our upper reaches go well into the subarctic and Arctic regions. Winnipeg is at the very southern area of Manitoba. We like to consider ourselves the heart of the country. I don't think those from Toronto think we're the heart of the country, but we will stick with that. Winnipeg is we're very close to the US border, so most of us have spent much time traveling this region at hockey tournaments or things like that. We're just about an hour from Grand Forks, North Dakota. And we have our own Miami. So between Winnipeg and the US border is Miami, Manitoba. It is a very small farming community based around a grain elevator. And this is the community, this is it. What you see is what you get. There are no beaches to be found anywhere near Miami, Manitoba, just wheat fields. And in fact, this is what it looked like about 10 days ago when they got hammered with some snow. So I know we have much in common. So the objectives of my talk are really to define pediatric to adult healthcare transition and describe some of the characteristics and common challenges of the period, to identify some key elements and core components to the transition process, and then to look at different models of transition. So what is healthcare transition? So it's defined as the purposeful and planned movement from pediatric into the adult healthcare system for a young person living with chronic illness. That's how it's classically defined. It always is referring to the population of those with a chronic illness. But I think it really does apply to healthy young people too, who will have to seek healthcare within a different system. The goal, of course, is to prepare and to support that young person living with a chronic illness in the context of their life at that time and their developmental stage, with hopefully that there will be no gaps in care, so that there's no loss to medical follow-up. This differs from care transfer. Well, care transfer is part of the transition process. Transfer really just refers to your discharge from one clinic and you take up care in another clinic, whether that's moving from one city to another within the pediatric years or transfer from a pediatric to adult clinic. So care transfer is part of transition, but transition is a whole process. So why is this an important issue? Well, I was looking for some stats to support this. It's a very large number of people. 15 to 18% of youth in North America are now estimated to live with a chronic health condition. And the vast majority of those young people now live into at least young adulthood, if not well into the older ages. And of course, that's changed pretty rapidly over the last, well, not 20 years, but 20 to 50 years, where many childhood onset diseases where kids didn't survive into adulthood, that is no longer the truth, and the vast majority do. So it is a new population, but it is a very large population. And of course, kids are, I'm going to say kids, but I shouldn't, youth who live with a chronic illness also undergoes psychosocial and physical developmental changes that accompany normal, every adolescent and young person. We know that there's potential for serious consequences if the transition process is not well done or if there's poor transition. The easiest to measure is actually disengagement with the healthcare system and loss to follow-up as they move from pediatric to adult healthcare systems. There have definitely been shown increased hospitalization rates in the population that doesn't transition well, and interaction with the acute healthcare system. So they may be lost to their chronic healthcare system, but we see them emerge with increased rates, troubleshooting in acute healthcare. And certainly detrimental long-term health outcomes have been well documented for those who fail to transition well. Problems that have been identified include inadequate planning. Surveys of caregivers and young adults have shown to actually more than 50% have indicated that the process of transition has never actually been discussed with them. We know that there can sometimes be poor service coordination between the pediatric and adult healthcare system. And there really is a lack of resources that is targeted at this particular age period or period of life. And we know there's gaps in education and training, both for the patient and their caregivers, but importantly also for healthcare providers. The issue of transition, or this period of transition, is still often not addressed in medical training systems, in pediatric or in adult residencies. And I know from discussion with my colleagues from other health professions that that is also true in non-MD training programs. And of course, this is a time of changing roles for everyone. And changing roles, change can be exciting, it can be fun, but it's also a stressful period for everyone. So it's a time of changing roles for the young person, for their caregivers or supporters, as well as the healthcare providers. So early on, when a young person might be quite a young child diagnosed with a chronic illness, that young person receives care. Their caregivers are their parent or primary caregivers are responsible to provide that care. And as healthcare providers, early on, we carry a major responsibility to ensure that we've given the family the tools and that child actually receives care. So we don't tolerate a 5-year-old not receiving the care. We bear that responsibility to make sure it happens. As the young person gets older, they start to participate in their care. The family or caregiver become managers, and we become supporters to both the youth and their families. As they get older, the young person moves into sort of a management position. They become in charge of managing their chronic disease. The parent or primary caregiver has to move from being in charge to being a supporter. And as healthcare providers, we become more of a consultant role. And as you move into the adult world, that young adult now becomes the CEO of their chronic illness. They are in charge and supervisor. Their support system, whether it's primary family or others, their support systems become consultants, and we move to more of a resource role. And again, while change can be fun and exciting, it is often difficult. And I think we need to acknowledge that there's lots of change for all of us involved in the care of young people with a chronic illness. So what are some of the characteristics and common challenges of this period? So I'm going to introduce the term emerging adulthood, which was coined by Dr. Arnett, a clinical health psychologist, about 20 years ago now. When he originally coined it, he was referring to 18 to 29-year-olds. It is often used to refer from 16 to 26-year-olds, but the late adolescent to the young adult. And this is now recognized as a very specific period in our life with specific challenges and benefits. And I had a look at numbers in the US in preparation for this talk, so I hope my use of the census data is correct. But when I did some addition, it's actually 20% of the US population is in the 15 to 29-year-old age group. So this is a very large population. And some of the characteristics of the late adolescent emerging adult period have been described by Dr. Arnett as the age of exploration or the age of possibilities. It certainly isn't all negative. This is a fun and exciting time where people are figuring out their personal niche in life within their social circle, within their sort of educational or vocational circle, within greater society as its own. It's a time where identity is established and cemented. It's a time where people make pretty important educational and vocational choices. Listen, we can change our vocation and go back to school at 40, but this is the classic time where people are setting the stage or the pathway for the rest of their life. But at the same time, it is also the time where there's the highest rate of risk behaviors, of health risk behaviors, use of alcohol, illicit drugs, risky recreational behavior. As a pediatrician, I always thought that was the 16 and 17-year-olds. It's actually the 20 to 25-year-olds who have those highest rates. And at the same time, in the US at least, it is a period of time where people have the lowest rates of health insurance and the highest rates of poverty. So you can see how some of those fun and exciting things can combine with high risk behaviors, and poor health insurance, high rates of poverty can combine to provide some challenges. If you are a young person living with a chronic illness, as you become an emerging adult, you've got all of those things going on, but it's also the period of time where they're assuming more responsibility for self-care and assuming responsibility for their interactions with the healthcare team. Listen, in pediatrics, if kids don't show up, we go and find them. You don't show up in the adult world, it's assumed that you have made those choices. It's the period of time where they also may be losing some long established relationships with their pediatric healthcare team. And we know from repeated publications, it's a very common theme that it's a period where their interactions with the healthcare system decreases, with the exception of emergency care. But their use of the healthcare system overall decreases, and that is particularly true for males. And so it becomes a very complex period of time with its own particular challenges. So what are the characteristics of the healthcare system? And listen, I am going to give you a bit of a generalization here. I know it is not true of every pediatric clinic or every adult clinic, but there's some general characteristics that I think we need to be aware of. In the pediatric healthcare system, our focus tends to be very much on not just on the youth, but the youth within the context of their family. So we focus on the family. At least in specialty care, there is a move towards more one-stop shopping. So in diabetes, for example, which is my biggest experience, it is a very common model of care to have a one-stop shop. So an interprofessional co-located team might be a nurse practitioner, a nurse educator, dietitian educator, social worker, psychologist, endocrinologist, who are all co-located, providing care together. Communication, of course, is, yes, the child is included in communication, but it is with the family. We are often almost accused of having the luxury of time. We sometimes don't feel like we have the luxury of time, but we in general have a little more time. It is the parent or primary caregiver who is the primary decision maker, who gives consent and is the primary advocate for the child. As you move into the adult healthcare system, there's quite an abrupt change. Certainly in Canada, you know, sometimes we're legislated that it must occur at 18 or 17, depending on your jurisdiction, and you abruptly change to a focus on the individual. Resources are often not all together. In the diabetes world, the typical model in the adult diabetes world is you might see your adult endocrinologist. You may often see a nurse educator, but it may not be at the same time or physically together. So that adds complexity and time to your life. The communication moves to directly with the patient themselves. In general, our adult colleagues have less time available and often say that they feel very rushed. And it's the patient themselves, in the absence of issues related to ability to give consent, who is the primary decision maker, gives consent, and becomes their own advocate within the system. And in North America, there is often a bit of a discord. Of course, this is a generalization. I have one very independent 20-year-old and one very non-independent 19-year-old. But in general, in North America, very few 18, 19, 20-year-olds pay their own mortgage, pay their own rent, are responsible for budgeting and doing the groceries, making the food. They may do their laundry, or they may be hounded to do their laundry, and many still live within the context of the primary family home. And even if they're away at college, they may be within a residence where some of those duties they're not responsible for. But our healthcare system is quite out of step with this socio-cultural reality for the 18, 19-year-old, 20-year-old, where suddenly you're 18 and you become responsible for making the appointments, attending the appointments, making sure you have health insurance, getting your medications, applying any treatments. And it's a little out of discord with where young people are often at in terms of stage of the rest of their life. So how do we bridge this gap from the pediatric system to the adult healthcare system? Well, I think this is very much a shared responsibility of pediatric and adult healthcare providers. And I actually think that that's something we need to focus on. For sure, young people and their caregivers play a role and can inform this process and are very important to it. But in the past, it's been very much and here's my pediatric bias, but I think it's true, it's been driven by pediatrics. And I think we need to join and partner with this to bridge that gap most effectively. What we're not going to talk about today, which has always struck me as funny, but it's not going to be part of my talk, is we talk about the differences between the systems and how do we help people transition from one to the other. I am still not sure why we don't all go back and say what works well in this system, what works well in that system, and make them come together. I'm not sure why we have to have very different systems. That is the reality of today. But I do think we should pay attention to what works and why can't we merge the systems a little bit better? But in the absence of doing that, we need to bridge this. And I think this is very much a shared responsibility. And I think it's only going to work well if it is a shared responsibility. So what are some of the key elements to this process of transition? So some of this is going to be opinion, and some of that I'll tell you where it comes from. So there's a couple key elements that I think need to occur. There needs to be somewhere in the process an assessment of the individual's readiness for transfer, which might include assessment of some medical facts, some treatment facts, but also an assessment of their understanding of the system and how you navigate the system and how you become your own advocate. There, of course, if you're going to assess transition readiness, you have to have some design for how you address any deficiencies that are addressed. I think it's really important to address differences in providers and models of care. We can't pretend it doesn't happen, so we might as well put it out there to help young people become best prepared to make that move. And I think there needs to be a support system that moves past the end of pediatrics into young adulthood to help young people adapt to a change. There are 6 core components that have been adopted by many organizations. I've referenced the American Academy of Pediatrics here. They have a clinical report on transition, but it's been adopted by many other organizations, the Canadian Pediatric Society, the American Association of Physicians. There's about 7 or 8 different large organizations in healthcare that have adopted or put their name on these 6 core components. And those are, I'm going to review those sort of briefly individually. So if this is my timeline on the blue arrow of kind of transition from early to mid adolescence through to adulthood, above the line are sort of the 6 core components, and below the line are sort of how we can think of individualizing those or applying those core components to an actual person. So the first core component is actually to have a transition guide or a transition policy. It's often called a policy. I think guide is a better word because it can be a living document, and policy sounds a little bit too much like policing. But some sort of document that is tailored to your specific situation and population, that is ideally developed with input from caregivers and young people in that population, as well as both adult and pediatric health caregivers. I'm going to give you a few more details of that in a slide or two, so I'll hold off on that. But if you're going to have a transition guide or policy, you need to discuss it with the individual. The suggestion is it's sort of early, and some of this is going to depend on the developmental stage of the young person, but somewhere in early adolescence to actually review that policy with them to set the stage. Over the next 10 years of your life, we are going to look at making sure you have these skills, that you understand the healthcare system, things like finances, you know when we're going to transfer you to adult care, and what the expectations are of adult care. So it needs to be reviewed, and it doesn't have to occur once. That can be an ongoing review as people go through the process. The second core element is a method of transition tracking and mentoring. So if you think there's things that they need to know, you need to be able to track it and then have a system to mentor that individual and their family to achieve those skills. So there needs to be a tracking process for the individual. I'm going to share an example of one. You can do it in many ways, and that's an ongoing process. I've put the pediatric years here, but probably goes into the young adult years. And then there needs to be that formal assessment of transition readiness, and it doesn't need to occur once. It could occur multiple times over a 10-year span to look at what skills that individual has. So you can identify the deficits and then customize your education to that individual. The fourth component they call transition planning. This is all transition planning, but that refers to the development of a specific healthcare plan for the individual. That would include a medical summary, that would include reviewing it. Depending on what you're dealing with, there might be an emergency plan that's formalized, and it would go with that they would have copies of it and it would go with them. It also includes discussion with that young person and their families. Where would they like to be seen in the adult world? You know, in some places there's no choice, there's only one place to go. But for example, in the my diabetes world, I have adult colleagues around the city. in our geography, healthcare is very centralized into the city, but they have choices of where they want to go. If they're going to one of our universities, there's adults who are much closer to that. If they're going to our other major university, they may choose to go somewhere else. So an individualized plan that they have input into. The fifth core element is the actual transfer. And the age of that varies. In some places it's legislated. It's legislated for us. So it's not, you can't individualize it. It must occur by age 18 in my world, but that does depend where you are. But the actual transfer and integration. And the sixth component, I don't think I personally have done very well, and we're working on this now, is the completion of transition. So it's confirming that that young person has actually made it into adult care, that they're integrated in adult care, and it is a huge opportunity to elicit feedback from them to help improve the system. And this is an area that I've not, I think I say we, so our team has not done as well as we'd like to, and are working on trying to take that next step in partnership with our adult colleagues. So we want to know for sure that they've gotten there, that there aren't any other areas that need to be addressed. So a few more details on a transition policy or a guide. Again, it ideally should be developed with the caregivers and the youth themselves, but for sure adult caregivers need to be a part of this. If as pediatricians we decide we're in charge of this, that's actually not really fair, because we're setting the stage and saying what's going to happen as you transition to adult care. Well, it needs to be informed by our adult caregivers. It describes an approach to transition, and this can be very individualized to your clinical setting. It needs to include some things about the adult approach to care, include privacy and consent. We need to talk to kids about that, the age of transfer, sort of an outline of the process within your clinic. And this, most importantly, needs to be reviewed regularly with the healthcare team. I've become acutely aware that you get new team members who didn't know this existed. So it needs to be out there all the time and reviewed with the family on an ongoing basis. And again, ideally it's a document or a guide, but it's a living guide. So it shouldn't be static. It needs reassessing all the time. So that second core element was transition tracking and mentoring. So that's kind of a very general thing, but it really comes down to how do we mentor young people and their families to make that transition, to assume responsibility for self-care, to understand their disease, and to understand the different medical systems. So that's really content. This is an example from an electronic medical chart. It is, I'm sorry, diabetes focused, because this is what we are currently using and remains a document that keeps evolving. But because it's from an electronic medical chart, this isn't a static piece of paper. But when you open a young person's chart who's in the adolescent years, you can find one document that gives you a history of where they are along that process. We've divided it, and this was developed with families and young people involved, into self-management skills, lifestyle issues like education, sexual health, living on your own, annual exams that are diabetes specific that all kids need to know. They need their foot exam, their eye exam, things like that. And then a section I'll look at more closely related to the medical team. But it's not a static document. So when a child is 13, we might just, you can put the date of the visit in there, and whoever had the discussion might review the transition process and our transition guide. They might touch on some diabetes self-management skills. They might touch on some lifestyle skills. At their next visit, somebody else can see what's been done and might go back and see what their retention of that knowledge is, and then address some other issues. Our goal is, ideally by the time of transfer, that all of these issues have been touched on. But for individual children or young people, there may be reasons or other things that they're not. But the document will then go with them so their new providers can say, they've only had a chance to really talk about sexuality and healthy relationships once. Maybe we should be touching on that in our first couple visits. So it is a document that is built on. This is just a close-up of, and again, we've come up with, this would be individualized to a clinic. We came up with this with the input of families and youth of what they felt were the key self-management tools. And again, you're not meant to touch on it once. It's kind of, most of us need to hear things 3 times before we remember them. Of course, these are things the families have already learned, but if you're diagnosed at 5, the focus was on giving your parents those skills. We need to put the focus on the youth now acquiring those skills. And we have a section we call medical team, but it's really you can use other terms. Within our program, and I'll show you that later, we have in mid-adolescence, a youth class, and in late adolescence, a second class. This is just a way of tracking, did person X, have they been invited to a class and did they attend? Or, oh, we should invite them to the next class because they haven't been to class 2 yet. This is tracking whether there's been a discussion about what their first adult visit looks like, preparing for the first visit. We want to be sure they also have primary care. Have we discussed that? We can help them find primary care. Have we reviewed transitions options? Because we are fortunate that we actually do have options. We have a young adult clinic that young people can choose to be referred to. They can choose to be referred to the endocrinologist their mother sees if they want. They can choose to be referred to someone who is close to school or work. And once they've chosen the team, we want to make sure that that decision has been made with them. And this is just tracking and documenting, have they been referred to our, I'll tell you about the Maestro project in a minute, but referred to our transition coordinator. And if they haven't been, have they chosen not to be and why? And that's to help us learn. And then do they know where this actually needs to be changed? Because it used to be a binder and a package. Of course, we've moved to online and virtual resources, but do they know how to navigate resources that we have posted for them? So again, it's just a way of tracking and then using it to guide education. This is another example from the GOT Transition Program, and I'm going to forget the name of, it's the National Association for, oh, I'll forget, I've got it written down later, Advancement of Adolescent Management, something like that, which is a US funded program. The GOT Transition Program had a very large federal grant to fund it. And this is their sample transition flow sheet. More generic, but has the same components of what we do in our own diabetes clinic. The components are the same. We have customized it to be less generic, but they also talk about, you know, has the transition care, the process and the policy been reviewed? Has there been assessment of transition readiness and self-care skills? Has a medical summary and a plan and an emergency plan, if this is something that needs an emergency plan, been made and shared? Have we discussed the adult model of care and specifically changes in decision-making, consent, and privacy? Has that been discussed, and does this young person understand that? They've also added legal options if you have a young person who will need supported decision-making because they don't have the capacity for their own. And then ongoing care, which is our medical team. So it's very similar, a little more generic, but can be adapted. And then most importantly of those components or key core components of a transition program is assessment of readiness. And again, this is not necessarily a one-off thing. It can occur several times during the process to help determine the timing of transition or the actual transfer for an individual. It can be used to enhance education and intervention at a program level, because if everyone you do an assessment of readiness says they don't understand how you make appointments in the adult system, then the program needs to improve that area of education, but can also be used to personalize the transition process for the individual adolescent and young person. And there are a number of tools. I'm just going to share some of them with you. There are a number of tools, because I'm not a big believer in recreating the wheel, that have been developed to help with this. And I'll share a couple of them with you. So the TRAC program, which stands for Transitioning Responsibly to Adult Care, is a program designed by the BC Children's Hospital at the University of British Columbia. Their resources are available and free. And again, its goal was to support youth with chronic conditions, bridge that move from pediatric to adult care successfully without a fallout to care. And they have transition readiness questionnaires, which are available to anyone. They have two. One is aimed at the caregiver, and one is aimed at the young person themselves. And they focus on skills for self-management, and these are generic. They are not disease specific, and they focus on skills for self-advocacy. So here's an example of the Am I on Track questionnaire for the adult or the primary care provider. I know you can't read all that, but again, it focuses on knowledge indicators, so self-care, and then the advocacy or behavioral indicators. They're very easy to fill out. They're meant to be self-filled out, but you certainly, if somebody has a literacy issue, can help them with it, and meant to be done very quickly. So the knowledge indicators, the caregiver rates either strongly disagree to strongly agree. And here's some examples, like my son or daughter knows how to access their healthcare records. They know how to describe their healthcare conditions to others. So, you know, when their young person is 14 and they fill this out, there might be a few things here that, yeah, my son or daughter really, they've got that. I strongly agree with that. But there may be many that they really haven't started yet, or they're kind of in that in between. And the behavioral indicators, they rate anywhere from they never do or they always do. And they're things like my son or daughter asks their healthcare professional questions about their health, or they take their own medications, or they know how to get their own medications. So the goal is to get everyone towards the end of this, but it can be used to identify areas for that individual from the perception of their caregiver that they need extra support in. The youth one is a little more colorful, but again, it's a pamphlet. It's very short. It's divided into 6 categories: voice, action, connections, future planning, things like job, education, sexual health, and safety. And the youth essentially either checks, yeah, I got that, or yeah, I'm not going to check that because I need to do a little extra work on that. And these are just examples of questions under voice. I know what my long-term health problems might be. So they either check, yeah, I got that, I understand that, or yeah, I don't really know. So then you put an X there. Under action, there are things like I know how to fill my own prescriptions. I know what my own home treatments are, or I know why I have my blood tests done and I know how to get them done. Always interesting to see the difference between the caregivers and the youth self-report, because they don't always match up, but they often do, and then can be used to identify specific areas for that young person. So that's developed by the University of British Columbia. There's it's free and it's online. The University of North Carolina has also developed what they call the STARx program, that stands for Self-Management Transition to Adulthood with RX, meaning treatment. Again, they have transition readiness tools that are on their website and available for use. And they have self-report questionnaires for the pediatric age participant, for the young adult, and for their caregivers. So kind of 3 different questionnaires that are self-report that focus on 3 domains: communication with the medical provider, disease acknowledgement, and self-management skills. And they're designed to be done in a couple minutes a piece. So again, not time consuming. And then they have their transition questionnaire, which is provider administered. And It's a little bit longer. I think it's 32 questions, and they focus around the type of condition or disease specific questions, treatment questions, adherence, the role of nutrition, self-management, issues of sexual health and reproduction, vocation and school planning, insurance, ongoing supports as that changes, making sure that there's some ongoing support systems identified, and then questions around their understanding of their new healthcare providers. So that is meant to be administered by the provider themselves. All of these questionnaires, the TRAC and the STAR programs, have been validated. I am not a expert in qualitative research. Some of them have been content validated. Some of them have, but in the different realms of validation, there isn't one that is perfect for everything, but they have been shown to be predictive and identify those who will fall out of care if the gaps aren't addressed. So what about transition models? So those are just examples, and there's others out there of how do you assess readiness and then use the information to help the individual and their family. So what about transition models? So there are, when you look in the literature, there's 3 categories of transition or models of transition care that are identified, but it's really important to understand they're not mutually exclusive of each other. And I'll tell you right now that the literature that looks at sort of hardcore randomized controlled data, high level data of what works and what works, there's very little out there. Most of the evaluations of the different models are sort of pre and post. How did kids do before we did this and how did kids do after? But it's an emerging area. The first category are models of care that focus around a navigator or a transition coordinator, so an individual that helps bridge that gap. The second looks more at a program and a curriculum. And the third looks at specific clinic setups to help in the transition of care. So more the actual how we provide the care. But again, they're not mutually exclusive. I'm going to share with you a model of a transition coordinator or a navigator. This is the Maestro project, which is a project we started here in Manitoba. I think it was about 16 years ago now. So it was pretty new when it started. It's not so new now, where we have an individual who helps in the young people and their families navigate the system. She's the conductor, so we call her the maestro. She is not a healthcare professional in this particular program. She is there to help navigate the healthcare system, not provide individual education. She meets with young people between 16 and 18 and then stays in contact with them as they transition into adult healthcare systems. She does all sorts of things. She puts on educational events, like where she might invite, it's not individual education, but she might have a speaker. Sebastian Sasserville, for example, is a young man who lives with diabetes who's gone up Mount Everest. And he came in and did a talk, and it was a dinner event. They also do non-educational group events like, you know, the diabetes walk for fundraising, or they have a coffee club. And part of that is to actually create a sense of community and to provide peer supports. She does have educational resources that healthcare providers have put on the website so that if you've forgotten what to do when you're sick, you've got a place to go to. There's newsletters, and then she provides individual support navigating the system. So for example, unfortunately, in the system I work in with, if as a young person you don't show up to your adult healthcare appointment, you might actually need a re-referral. For sure, if you miss 2 appointments in a row, they're going to expect a re-referral. Well, I'll tell you that 19-year-olds don't want to call me up and say, Dr. Liz, I didn't show up. Can you help me out? But they can contact Catherine, and Catherine will make sure that they get back into the system. She also, for example, youth with type 1 diabetes, well, and type 2 diabetes require an annual dilated retinal examination. So she keeps an updated list for across the province of healthcare providers who will do that exam. Do they charge? Do they not charge? Where are they located? Are they down this, you know, so that if people don't know where to get their eye exam, she can connect them. And we have evaluated that program a while ago now and did demonstrate a significant decrease in loss to follow-up in the 1 year post-transfer to adult care. There is a fairly new multi-center randomized controlled trial out there now looking at a transition coordinator. Again, I apologize, but in the diabetes world, but it's one of the only randomized controlled trials out there where they looked at the 18-month transition period, the last 6 months in pediatric care and the first 12 months in adult care. They identified, you had a transition coordinator who actually was a certified diabetes educator, so they could provide some individual education as appropriate. But during this 18-month period, they maintain regular contact with the young person, often electronically. They used text, email. I think they had a Facebook account. But so they were educators and they kept in contact with them. But they also kind of acted as the mother. So they sent appointment reminders. They helped to reschedule if you missed an appointment. And they also facilitated referrals to other support. So if a young person was really struggling, they would facilitate, say, a connection with psychology. They looked at many outcomes. They did not show an improvement in control of blood sugars, but they did show that there were more for those who were randomized to having a transition coordinator, they did have more clinic visits. And from a qualitative point of view, they reported greater satisfaction with care and less diabetes distress. What they did not show is that persisted. When the transition coordinator got cut off 12 months into care, visits were lost. So what we don't know is, should we always have a transition coordinator, somebody to help navigate the system till you're 99 years of age, or should this be a 3-year period? We just don't know. And the other, I'm cognizant of the time, but I'm almost done. The other sort of structured program, so you've got a navigator. There's also kind of more structured programs where there's a defined transition program. This is an example of one. This is our current program where we have an ongoing checklist to track transition process. Young people have individual healthcare visits every 3 months, which is the standard of care in diabetes. So we introduced the healthcare, our transition policy around 12 to 13 years of age. In mid-adolescence, we have a group class, and in late adolescence, we have a second class. Those classes give information that aren't personalized, but everybody needs to understand the pathophysiology of diabetes. Everybody needs to understand insulin action. So we tried the classes in part so that it can, again, create a bit of sense of community and peer support. The classes are joint with the caregiver, though they both have individual time where they're split out, because of course the caregiver may need support in transitioning to their different role. And during each of these classes, during a break, the on-track questionnaires are filled out, both care provider and youth, and that information is then taken back to their individual visits. So that using the questionnaires, we identify what will inform what we do in their next visits every 3 months. We're not so good here at sort of this assessing of how well people have transitioned to care, and we're currently working on that. But that's an example of a structured program. And then the third basic model of healthcare provision looks really at how, like, actually specific clinics. So we have a pediatric healthcare and adult healthcare. There are models of care where the adult providers have physically gone to the pediatric care setting for the last visit, the last 3 visits, the last 6 months, different models. But the concept of the adult provider going to the known and comfortable setting, so then they become the known person as they transfer. There are studies out there that have looked at the opposite, where the young person travels with somebody who's familiar, one of their pediatric providers, for the first visit or the first couple visits to adult care. There are models where you have combined adult clinics, completely separate clinics. So you have pediatric care, you have transition care clinics where both providers attend, and then you have separate adult clinics. And then there are clinics that have been designed that they're not really a combined clinic, they're young adult clinics, they're transition age clinics that you don't, 99-year-olds don't come to this clinic. It is 18 to 25-year-olds, or 18 to 22-year-olds, depending on the clinic model, so they can focus on the supports that age group needs. There has been evaluations of all of these models done, but none of them in a randomized controlled fashion. And they basically all show that doing something where there's some continuity, some familiarness, improves visit numbers in adult care. That may not be and satisfaction. So those are kind of three basic models where you have a navigator, you have clinic types, or you have more of a curriculum, but of course they're not mutually exclusive. In my own clinic, we have a navigator, we have a curriculum, and we are fortunate enough that one of the options for young people to choose is a young adult clinic. I think the common thread on all of these is communication between the healthcare systems and trying to provide some sort of familiarity or continuity between them, even if it's just a little piece. So that's really what I wanted to say. In summary, healthcare transition is it's kind of a fun period, actually. It's a fun period in your life, but it is a very vulnerable period, and it is becoming, from a healthcare provider's point of view, there are growing numbers of people who are now young people with chronic illness who need successful transition. I doubt that there's going to be a one-size-fits-all for any specific disorder or any person. There may be individuals who respond to a transition coordinator much better than transition classes, for example. I do think there's some core elements that can help guide the process. And it's certainly, as all learning is, it's an iterative process. It's not kind of a one visit and you're done. And I'll just remind you, the goal is to prepare and support that young person who's living with a chronic disease in the context of the reality of their life, their social, economic, physical context, and their developmental stage. These are just the websites of some of those major programs. So it's the National Alliance for Advancement of Adolescent Health, that is a US federal government sponsored program that has a fantastic website and tons of resources. All three of these programs use those 6 core elements as their fundamental piece. And that is really what I wanted to share with you. I am always cognizant of what our patients and families teach us. My mentor, Dr. Heather Dean, has been she's now retired and the grandmother extraordinaire, but has been very involved in raising the issue of transition, and my colleagues who are very interested in transition in our own clinic. And Catherine is our maestro. And that leaves us with just about 11 minutes.
Thank you so much, Dr. Sellers, for that excellent presentation that covered so much ground in this area transition. We have at least 5 minutes, I think, for questions and comments. So let me open up the floor for anyone who wants to ask some questions. While you're preparing your questions, I've got one in mind, Dr. Sellers, and that is, when you first began, you gave us a figure which was really astonishing to me, which was that about 50% of families surveyed said that they actually hadn't discussed transition. I was just kind of astounded by that. Was that relatively older research? Was it across chronic health conditions, or?
So that was that figure appears in lots of different publications. And it's across health conditions. Mm-hmm. And the most recent review that sort of gathers all sorts of stuff is about 4 years old. So it's not 20-year-old data.
Right. Okay. Yeah, because it's a hot issue, obviously, for all of us, and it's amazing to hear that, given how current this issue is, that still families report.
And listen, there's much room for improvement that we're continuously trying to do in our own patient population and clinic. And every now and then we hit a young person who's about to be 18, and we realize that other acute issues in life have derailed us from paying attention to the process of transition. You know, they might be a child who has very significant psychosocial issues and mental health issues, so that we've been so busy doing that we realize when we look at our transition tracker, we haven't done it. So there's lots of reasons to get derailed, but I think it is an issue we really need to address.
Dr. Sellers, thank you. This is Danny Armstrong. That was a great presentation. I guess one of the questions that I have is that much of what you looked at was transition and diabetes. We struggle with other issues that with more complex disease that involve multiple specialists. You know, childhood cancer survivors, sickle cell disease, children with Down syndrome, and other neurodevelopmental disabilities. And one of the issues that we run into a lot is that while in something like endocrinology, there's a straight pathway to adult care of a disease, with specialty components that come in, but the primary is endocrinology. But in a lot of the others, you know, the issue may be primary Down syndrome, but we have to start thinking about what's the cardiologist doing, and congenital heart disease as we grow, as someone grows up that needs the work of a pediatric interventional cardiologist to know the plumbing, but yet the issues are GI, pulmonary, and around. Did you have suggestions? What we've done is rebranded transition into lifespan care, but do you have thoughts about how you engage an adult healthcare team that, as part of their training in medicine, really did not include management of children growing up with complex?
Yeah, absolutely. And there's a number of models of that. And in fact, we struggle with that in endocrinology, because type 2 diabetes, for example, in adults is managed by primary care. That's the model. It's not specialty care. And children with type 2 diabetes often have multiple, like they're a different breed, and we don't know what to do with them, actually. There are lots of emerging models, for example, in pediatric cardiology, where there is adult aged programs for congenital heart disease to try to bridge that, where they literally bring in both the pediatric, because some of that anatomy stuff, the adult cardiologists, okay, they might have learned it in medical school, but they don't know now, and they're joint clinics. But it does involve engaging adult care providers, and the struggle that we've had, which may differ in different medical systems. Like, listen, we're not a privatized system, and we still struggle, is the focus on the individual within the context of their family and life is not the training of our adult colleagues, but it needs to be. And I think transition care needs to be in the training of all adult physicians and all, whether you're a family physician, whether you're an adult cardiologist, because it is changing for everyone. Cancer has, at least in Canada, has probably been the most successful in that there is an acceptance that the pediatric oncologist will remain involved until at least 21 to 25 years of age, so that they do joint clinics. And that's actually a very common practice now in Canada. And I think they've led the way, but you need everybody's buy-in that it's important. And that, I think, goes back to education, which really starts day one in medical school, or day one in nursing school, day one in that those things are important.
This is Monica with Epilepsy Florida, and you touched on one of the questions that I had, and how are you tackling the challenges around that communication and collaboration between the pediatric and the adult care provider, they communicating amongst each other during the transition, and for it not to just be a handoff and, you know, here's the facts of all the medical records, but actually truly communicating.
So I think there's lots of different ways it can be done. You know, joint clinics or visiting each other's clinics is one way, but case management is another way. And I don't know your healthcare system in terms of reimbursement and barriers well enough, but one of the things that I know that people are trying to do, and we've tried to do, is literally have, and we do it virtually, we do it by telehealth, case management of, you know, these next 3 kids are coming into your system. Let's get everybody around the table, not just physicians, everybody who's involved in care around the table, to highlight some personal issues about that individual, because then they actually feel like somebody knows them when they get there, but also struggles. So yes, we spend more time on the kids who we know are going to struggle, but that conversation ahead of time, the feedback from young people is, well, I got there and they actually knew who my name was. Or because we'd had a conversation. And within our system, and I hate to say it because that shouldn't be why we do things, but there is a system for reimbursement for that, because for our adult colleagues, that was a barrier, that they are funded in a different manner. And if they're going to spend 15 minutes talking about a patient, they need to be reimbursed for it. But I think there can be case management, but it still all goes back to the buy-in from everyone. And that is called getting to know your colleagues and going at it slow and regularly. And there certainly are some people I know, actually in our neurology clinic, the neurology nurse clinician has been the bridge, because she in fact has probably the more consistent relationship in terms of being the first one people call for adjustment of meds or where they're in crisis. She has been the bridge between the pediatric and adult system, and actually accompanies a family. I go back to something I said earlier, and maybe it's just the phase of life I'm at. And again, it's a pediatric bias, so we don't do everything right in pediatrics, but I don't know why the adult healthcare system does not focus on family. And when I say family, I mean your support system. It doesn't have to be a relative. Because if you're a 38-year-old woman misdiagnosed with lymphoma, is it not important to know whether you have 3 little children and have a partner, don't have a partner, or that you care for an elderly parent? Like, is that not important? Like, or my 91-year-old mother who requires 24/7 care, is it not important they know that there are children involved who actually manage that care? So I think it's a bit of a culture change, and maybe it's because I'm getting older, but I unfortunately have no interaction with the healthcare system myself. But if I was sick, I'd want somebody needs to know that I run a busy practice and that I have youngest children for my gray hair, and I do have a supportive partner. So I think there needs to be a culture change. And I'm sure there's bits about, you know, we're criticized as pediatricians of model coddling our families. Well, maybe we need to be better at helping them self-manage earlier and take that from adults. But I think they can take family-based care, and I use family loosely. Your supportive base, your supports should be involved, whether you're 5, 18, or 92.
So we're about out of time. I know that folks have another meeting to go to, but I want to thank you again, Dr. Sellers, for a really informative and presentation. There's a lot of us could talk about this for a lot longer, and it was great to hear you talk about this. Well,
I'm happy to hear from anyone if you've got good ideas, because we're always looking for things that have worked in your setting. Please feel free to contact me. I'm sure you've got my email somewhere, Alan.
Yeah, sure do.
Because that's how we learn.
It's great to see what you already have institutionalized in your own setting, you know, where you, in the diabetes program, where you kind of,
but it can always get better.
Prompts and reminders.
Yeah.
Yeah. Great. Okay. Thank